So how are you? Let me start my task. I'm not muted. Okay.
With only people. Oh, apparently. Oh, but there's lots of people online. Oh, it's too cold to get out. Winter come unexpectedly.
Yeah, thank you. Oh,
Mhm.
does it not taken closer to your place?
Yes.
Yeah.
Me too, but there's lots of people online.
Is it open?
It's on.
It's on, eh?
Yeah.
Okay. Morning, everyone. Welcome to our meeting today, our one of the Global Health Seminar Series, and we are hosting the Director of C-Sharp, Dr. Hannah Hussey, who is with the Provincial Department of Health and the University of Cape Town School of Public Health and Family Medicine. Special recognition for the presence of our Vice Dean for Research, Prof. Nico. Thanks for joining us, and special recognition also for our colleagues from Bishop Lavis. Yeah, welcome, and let's make this an exciting event, because this is the first time really for us to host the C-Sharp seminar series. And also welcome to everyone who is online for this seminar today. And yeah, without much ado, I would like to invite Dr. Hannah to take up the the stage and provide the presentation, and then we'll have some discussion afterwards. For those who don't know me, my name is Peter Nyasuru. I'm the executive head of the Department of Global Health. Thank you. Welcome, Dr. Hannah. Thank you.
Thank you very much, Prof. Nyasulu, and morning, everyone. I'm very happy to be here. What I'm going to be doing today is giving you an overview of the C# project, talking about our progress and achievements so far, and then highlighting a few challenges we've had in Bishop Lavis before going into what I hope would be a good discussion around improving our collaboration with Stellenbosch University. So first of all, to just take a step back and explain what C# exactly is. It's a health and demographic surveillance system, similar to a census where you go to door to door to an entire population, but much more detailed. And it's updated more regularly, allowing us to create this dynamic longitudinal cohort. But what makes our HDSS unique is that it's integrated into routine community-oriented primary care, or COPC, which I'm sure many of you are familiar with, which is the continuous process of providing primary care to a geographically defined community based on their needs. And it relies largely on community health workers. So this HDSS, which is integrated into COPC, is situated within the two communities of Bishop Lavis and Nomzamo. And it aims really to strengthen and improve community-based services and test innovations that can be scaled to the province. And particularly important here is the work we're doing around digitization, where we've introduced a new mHealth app called CHAMP, or Community Health Action Mobile Platform. Sorry, there's going to be a lot of acronyms in this presentation. And this is the app that the community health workers use when they go door to door. And the other aims of C# are to use this app then to collect detailed electronic health, demographic, and socioeconomic data at the community level that's otherwise not routinely available, and ultimately to become a shared research infrastructure within the city. So we have two sites in C#. The one is Bishop Lavis, which I'm sure those of you from Bishop Lavis are particularly familiar with. It's a population of around 70,000, long-standing, predominantly coloured and Afrikaans-speaking, with more areas of formal housing. Our second site is in Nomzamo, near Strand. It's a newer suburb, rapidly growing with high levels of in-migration, more informality, and it's a predominantly Black African, Xhosa-speaking community. But these two communities were chosen because together they really highlight and allow us to explore the challenges that communities in Cape Town are facing, because obviously Cape Town is a very diverse and complicated city too. And then for the way C# is set up, it's got quite a sort of complicated operational structure and governance. It's led by the Western Cape Department of Health, but it's done so in conjunction with all academic institutions in Cape Town, including Stellenbosch University. Prof. Peter Nyasulu was on our C# steercom initially, and then Prof. Rene English took over this year. So the idea is that it's not just one university's project, but it's a shared academic venture. C# is then housed technically within the Provincial Health Data Centre within the Department of Health, but is part of a broader national network called SAPRIN, or the South African Population Research Infrastructure Network. So places like Agincourt and Ari are our sister nodes. We then work with the Health Foundation who administers our funds, and then the local Department of Health substructure teams, as well as the NPOs, because community health workers in the province are not employed directly by government, they're outsourced to NPOs. So it's the Carey Network in Bishop Lavis and Masi in Nomzamo. But what this all means then on the ground is that we've employed additional community health workers at our two C# sites, and all the community health workers do the same work. So they all do COPC and they all do C#. They just have a smaller area where they work in. So 3 or 4 streets that they are responsible for, that they are the frontline healthcare workers for. And they then have these streets that they provide their routine services for, do the normal COPC screening, check that the baby's immunizations are up to date to see if anyone's got TB symptoms. And then following on from that, they take informed consent and ask additional questions for C#. And all of this data is collected on the app CHAMP. on mobile phones. And so the community health workers can collect data offline, but where possible, the app syncs every 5 minutes with the Provincial Health Data Center and imports all the information that they've collected there. Once it lands in the Provincial Health Data Center, it allows us to automate various reports to support services. And so those are the screenshots you can see at the bottom here. But this also means that we can now digitize COPC services more. And particularly in our Nomzamo site, they've gone fully paperless. Previously, the community health workers carried various sheets and they counted activities on these tick sheets. Those tick sheets were then faxed or sent to substructure, and substructure collated them. And then it was this whole sort of very tedious manual process. But because the data is being collected electronically at source, it allows us to automate this process and hopefully make the work of the community health workers much more efficient on the ground and save other people lots of admin drama later on as well. And then just to say that there is plans to expand CHAMP use to other COPC sites in the metro, and the next one in the coming months will be the Klipfontein site with the Healthy Futures project. So what this looks like with regards to the consent and the data is that when the community health workers enter the households, they first ask verbal consent for COPC, and then they do the COPC questionnaire. Following on from that, they take C-sharp informed consent to ask information around the household. And then what we're busy introducing now is individual level consent. So they'll ask individual level consent from everyone at the household to get more personal information. And this also allows, when we do this individual level consent, this will allow us to link with existing health records at the Provincial Health Data Center as well. To give you an idea of the types of information that we collect, so at the COPC level, we start with very basic things like the GPS coordinates of the household, access to water, electricity, sanitation. We enumerate all the household members, names, age, date of birth, if anyone's on a social grant. And then for the medical component of COPC, there's a strong focus on pregnancy and postpartum, child health screening, HIV, and TB, and now increasingly a little bit more in the NCD space as well. And then when we get to the SAPRIN questionnaire, we really build on this information that we've collected at COPC and ask much more detailed things. So we ask, for instance, about what's the house built out of, what are the walls built out of, what are the roof built out of, does the household have access to internet, what household amenities and resources does the household have, what's the experience of food security, exposure to crime, etc. And then there's some additional questions coming through now with the individual level consented questions, including detailed histories around previous pregnancies, the partnership and marriage arrangements within the household, detailed questions around employment, and so on. So, but this is the data that we collect at C-sharp on CHAMP, but the real strength of C-sharp is that we can take this data that we've collected at the community level and then link it with what is already available at the Provincial Health Data Center. And maybe just a word on the PHDC. So the PHDC collates all available electronic health data in the Western Cape public sector. So this is admission data from Clinicom, hospital discharge summaries from ECCR, lab results from NHLS, electronic dispensing. And because wherever you are in the province, you have the same unique folder number, unique identifier, we can link all these different sources together to create a very comprehensive picture about individuals within the public healthcare system, regardless of where they are accessing services. And so, for instance, the bar graphs here at the bottom, this is just using the routine data from the PHDC to look at comorbidities, NCDs, and HIV in the two communities of Bishop Lavis and Nomzamo. And you can see there's already a very rich source of facility-derived data there that the C-sharp community data will augment. So in summary, what we have at C-sharp is it's a research project. It is a health and demographic surveillance system, but it is also integrated into health services at the front line when the community health workers are interacting with the households, but also at the back end through the data systems. And of course, we can't do any of this project without involving the communities. And so C-Sharp is really the combination of these three elements, research and academics, health services, and the communities coming together in this joint venture, which we hope to be a decades-long project. So that's a very brief introduction to what C-Sharp is and how it functions. I'd now like to give you a little bit of an update of our progress so far. So we started in 2023, and since then our community health workers, so it was 180 community health workers, have visited 20,000 locations, done almost 34,000 household assessments, and registered and collected information over 100,000 individuals. But you can see that the data is a little bit skewed because the majority of it, around 70%, is coming from the Nomzamo side. And this is, again, just a bar graph illustrating that difference there, with the red being Nomzamo and the blue being Bishop Lavis. And you can see that the Nomzamo site has outperformed the Bishop Lavis site markedly. There are lots and lots of various reasons for this. Part of it is that the NPO who employs the community health workers in Nomzamo is a larger organization with more CHWs. But there were also some issues with regards to community acceptance in C-Sharp. Not to say that the community didn't want us, but I think it just takes a little bit more time to develop trust and to build relationships in this setting. And of course, we had major issues around gang violence, particularly in Valhalla Park, where it just stopped services and data collection completely. But the bigger operational issue at the same time was also around the NPO. It's very difficult, particularly in this financial climate. Nice. Sorry, somebody's not on mute.
I
can't, let me just... So the challenge in the NPO space is really recruiting and keeping skilled staff, particularly when the salary levels are much lower than what you'd get in the government or the private sector. And then furthermore, there is this complicated sort of line management because the substructures contract out to the NPOs, but so do we. And so there's this this sort of dual reporting model that makes things a little bit more difficult. And so the plan at the moment is that we scale back our research surveillance in Bishop Lavis for 2026 to really focus on getting the basics of COPC digitization right, build a better foundation, including with the NPO, the substructure, and the communities, which will allow us hopefully to reinstate full surveillance next year. But stepping away from Bishop Lavis now and focusing on Nomzamo. So there, our 102 community health workers have reached over 70,000 people. With regards to the locations, we are busy developing our mapping systems, which I'll show you now, and our coverage is around 90%. What we've done is that we've looked at all the formal IRFs, and as you can see, I don't know, let me get a pointer here. Sorry, it's not, the resolution's not great. So what we've done is we've compared all the data we've collected to in the formal IRFs, and you can see everything that's highlighted. We have these are locations where we have information around the households, and you can see there's only a few scattering households here and there. The informal areas are a little bit more difficult, and so what we're doing now is we've developed this fishnet grid system. And we're busy trying to link the data that we've collected there to these fishnet grids. Unfortunately, when we started, we thought that because the community health workers are collecting GPS coordinates, we could use that in our mapping systems and it would make our lives easier. But if the GPS coordinates are often a little bit off, and by a little bit off by 5 meters off, And that puts you in a different shack in a different household and things. And so it really, unfortunately, wasn't usable. And that's why we've developed this this extra step in our mapping system. So that's with regards to our coverage. With regards to consent participation, so once the community health workers get access to the households, in Nomzamo, we have a 92% consent participation rate. So I'm going to share a little bit of our baseline data because we've completed our baseline in Nomzamo. Bishop Lavis, you'll see why the Bishop Lavis data is a little bit strange. So the population pyramid for Nomzamo is very fat in the middle because this is as expected, because this is predominantly people come into Cape Town to work, and if they're not working or employed, then they tend to leave Nomzamo. The population pyramid for Bishop Lavis is a little bit funny. So we are expecting to see more older people there, but you can see at the bottom of the pyramid there should be more children. We seem to be missing some people. With regards to housing type, so about half the houses in Nomzamo are informal, whereas in Bishop Lavis, it's a much smaller percentage. In Bishop Lavis, about 2/3 are formal housing. Again, that's sort of tracks with what we expect. But when we start going further into the data, it gets a bit strange. And this is looking at employment data for Nomzamo and Bishop Lavis. And this graph is looking if there's anyone employed in the household, but maybe we can just focus on this side here, where it looks at the household members' employment status. So the red percentage of people that are not employed, and 31% in Nomzamo is sort of what we would expect, but 65% in Bishop Lavis is not what we would expect at all. And similarly, when we get to social grant receipt, the numbers of households who get social grants in Bishop Lavis is higher than Nomzamo, even though sort of if you're just looking at sort of poverty, Nomzamo is a poorer community. And the problem really is that the coverage in Bishop Lavis is around 40%. And it's coming from mostly the home-based care clients, which are frail, sick people that the community health workers have to visit regularly. And so therefore, it's not a representative sample of what's happening, what the community in Bishop Lavis looks like. And the way a health and demographic surveillance system is supposed to work is that you go to every household. There is no sampling, and you need to maintain relatively high levels of coverage. And if you have incomplete data like we do at Bishop Lavis, it's really not usable because it's so very skewed and biased, unfortunately. So that's the situation with the Bishop Lavis data, but maybe just to say, I've put some other stats from our Nomzamo side. You can see we have information around water, electricity, internet access, and food security. And the idea is that we then take this information and set up mechanisms to share it, firstly with services. So this would be the dashboard that we're preparing on the top there, so that services have sight of the communities they serve, but also we need to share it directly with the community members themselves, so that they are empowered with information about their own community and they can use it for whatever purposes, whether it's to lobby for better access or improve services, etc. How we do it is actually quite a difficult, it's not as easy as it sounds, because this kind of, you need a certain amount of data literacy to understand these bar graphs, and how do you explain information to people in a way that they can understand it and use it without losing a lot of the nuance and the detail is actually quite challenging. So we're working on various community participatory projects, which we're going to be starting in Nomzamo in the coming months. And the one idea was that we need to display the information in sort of as graphics, cartoons that are easier to understand. And then, because we've completed our baseline assessment in Nomzamo, we're now starting our follow-ups. The idea is that we're going to have one long, detailed household assessment each year, followed with 2 short visits. And this will allow us to assess any births, deaths, and migration patterns. So if people are moving in and out of the household, allowing us to create a dynamic longitudinal cohort. But then we're also planning to start individual consent, as I said, and verbal autopsies. So the verbal autopsies are if the community health worker goes to the household and notices someone has died, then what they'll do is they'll schedule an appointment with the next of kin. And the idea is that by asking a set of standardized questions, you might not get the exact cause of death, but you get a rough idea of what it is, particularly at the population level. That'll be useful for mortality studies. The other sort of data input that we're excited about is our weather stations. So the South African Environmental Observation Network, or SAON, which is funded by the Department of Science and Innovation, sets up weather stations throughout the country. And the idea is that if they can set up weather stations within our health and demographic surveillance systems, we can use this local environmental data to assess how environment and climate change are affecting vulnerable populations. So this weather station is live at the moment. The data is publicly accessible online, and we're hoping to get our second weather station put up in Nomzamo in the coming weeks as well. And then obviously I'm talking a lot about collecting pieces of data and using it for research, but obviously we can't do any of this without properly involving the community along the way. And we've had various events at both sites. Some of them have been more large scale, like the big sporting event in Nomzamo, but some of them have been smaller, more hyper local activities focused through schools or churches or youth. And that we need to keep going to ensure that the platform remains sustainable. At the same time, we also need to acknowledge the role of the community health workers who act as frontline healthcare workers, as data collectors, but also they come from the same communities they serve. And so they often end up being an informal bridge between C-Shop and the communities, and how we capacitate them in that role is important. So I've spoken a little bit about the challenges that we've had in Bishop Lavis. We've tried to decrease the surveillance area, and we've tried to sort of various accountability mechanisms and things, but it hasn't really borne fruit yet. And as I said, we are scaling back our research activities in Bishop Lavis for 2026. But it's a really tricky balancing act, because how do you go into a community and you say you want to do this project, and then it's not working, then you say, okay, I'm going to leave, but I might come back. And how do you do that in a way that's respectful and dignified, but is also honest and pragmatic, and that keeps the relationships open, that you can still build on them, is something that we are still working through. But luckily, we've partnered more strongly now with Stellenbosch University, including Prof. English and Stacey Blaus, to coordinate the community engagement space a little bit more. But it still remains a tricky message around how you scale back for now, to leave the option to come back later. And then maybe just to be sort of very clear that C-Shop surveillance in Bishop Lavis is difficult, but we've already put significant resources into it. The current funding that we receive from SAPRIN is for one surveillance site of 100,000 people, which Nomzamo effectively gives us. And the idea of running these two surveillance sites, effectively two separate HDSSs, it is a little bit problematic. But I don't want you to get the impression that I want to leave Bishop Lavis at all, because it's really important that C-Shop, if it is to be representative of Cape Town and people in Cape Town and the challenges people in Cape Town are facing, that we need to include it, both politically and scientifically as well. The colored population is not otherwise represented in SAPRIN. And so it's key there that there is representation at that level. But also if we start thinking about long-term plans for biobanking and genomic studies, to exclude this population would really not make sense. But also in Bishop Lavis, we have an older population with a different disease burden, which really, both for services and a research point of view, would be a real tragedy to lose. And then maybe just to chat a little bit about the funding of how this works. So CSHOP builds on the existing COPC funding that the Department of Health provides. SAPRIN provides us roughly 12 million rand per year, and their target is that we reach 100,000 people. And then we've had significant co-funding from the University of Cape Town already, particularly SIDRI Africa, which contributes to staff salaries, and Healthy Futures, which is planning on expanding CHAMP use in Klipfontein in the coming months. At the same time, we have to remember that we're building a research platform on top of embattled community-based services. And the community health workers, the people on the front line on whom CSHOP entirely depends, they get a salary of 6,000 Rand per month. This was recently increased in April from 5,200. So that is a step in the right direction. But it is complicated in the sense that we as CSHOP can't pay our community health workers more than the standard provincial salary. And there are multiple battles going on between national and the unions about how we should fairly remunerate the community health workers. And there's also ongoing discussions around insourcing or keeping the NPO model. And so that's all happening in the background, but it's completely inescapable from CSHOP and the way CSHOP is designed with community health workers. Maybe just to say what we have done is we've tried to support our community health workers as much as possible. So we give them gifts of vouchers. There's, sort of things like stationery and jackets and backpacks and those sort of consumable things to at least make them a little bit comfortable at work. And we've now started introducing optional paid overtime on Saturday mornings so that we can not interfere with the set provincial salary, but we can give them a little bit of extra funding. And also at the same time, it will allow us to access hard to reach households. So that's the operational context which we have to bear in mind. Now maybe just to chat about the collaboration with Stellenbosch University. So Bishop Lavis was chosen as a CSHOP site specifically because of Stellenbosch. And as I'm sure you're all aware, Stellenbosch has a very long and rich history at the Bishop Lavis site, which we would like to leverage more. And we are doing this now in the community engagement space. But we do need additional funds and staffing in the Bishop Lavis to continue working in Bishop Lavis. But I'm not here to beg for money, which I am a little bit, but more to say that how can we work better together? What is the research agenda from Stellenbosch's side? How can we align more? How can we apply for funding together? There is some room in our individual consented questionnaire, which I'll share with you now, where if Stellenbosch has specific research interests that they'd like us to explore, that we can do that for them. The only caveat here is that the community health workers already have a long questionnaire to work through. So they start with the COPC questionnaire, which we can't fiddle with because that's set by Metro Health Services. Then there's the CSHOP household consented questionnaire, which again, we have limited influence over because that's our contractual requirements from SAPRIN. But now in this CSHOP individual consented questionnaire, we have a little bit of space. So we are asking some questions that that SAPRIN mandated we do, but our HREC felt was not feasible. So all the partnership questions, the full pregnancy, the detailed employment. but there's more room after that. So we've included questions around health facility use, barriers to health access, exposure to extreme weather events, and then some intersectional drivers of health, how people make decision making in their household, if they have, how they get health information, and how time poverty affects them. So the questionnaire, the C-Sharp individual consented questionnaire, is open to suggestions and additions, but obviously the only limitation, which is quite a major limitation, is around total length. And then maybe just one last word around collaborating with C-Sharp is that we have data, and we're not keeping the data for ourselves. We would like to share it with you and collaborate with you in using the data. There's a couple of mechanisms to go about accessing the data. And the first one is that if your research question can be answered using the data currently at C-Sharp, then you would just apply for ethics and then apply to the Provincial Health Data Center as normal. But if you'd like to use C-Sharp as a sampling frame, particularly in Nomzamo, that is available. And we can provide you with a sampling frame. If you want men or women of this age, etc., we would do that. You would obviously just need to provide other additional field workers to collect your detailed questions in that setting. And then the third option is if you would like your questions incorporated into the C-Sharp questionnaire, which is obviously a much more laborious process, and we can only really accommodate a very small number of questions, but then the possibility of a much larger sample size is available, and that we can talk through those options. So just to say that we welcome collaboration, and depending on what information you need, there are different ways to access it, but really we would like to start the discussions. And particularly I know if researchers are wanting to put in funding applications, it can be quite a sort of a drawn out process. And we would be happy to start discussions earlier rather than later there. So yeah, that's all from my side. Thank you very much.
Thank you very much, Dr. Hannah, for that comprehensive overview of the C-Sharp. Let me welcome questions. Prof. Nico.
Thank you very much. I have so many questions. Let's see what I want to ask them. I guess from my side, I think we have to. Also very interested in the fix plans. Can you this currently sort of write it down while you in time to also that would have long-term value for the community itself.
Prof. Niasulu, colleagues, could you just pass the microphone to the person asking the questions so that we can hear it?
Okay,
thank you.
Thank you. Sorry, thank you. So, without repeating everything, I think the biggest question at this stage to me would be an interest in the genomics long-term potential for these sites, and what are the current thoughts around that, and what are the opportunities for us to become involved in that?
So as of now, there's no genomics data collection, but the other SAPRN sites, when they do the individual consented sections, the community health, their field workers collect dried blood spots usually, and that gets sent and you can be used for various genomics and other studies. The idea is that we're a very new node. We only started in 2023, and we're just about to introduce the individual level consent. Once that system gets more established, the community acceptance is there. We could be open to doing that. We would, however, need additional funding, of course, for that. But in the next year or two, that's definitely something to explore.
Thank you. So, I mean, I think that's one of the. So my thoughts around the acceptance, and I mean, the colleagues will need to tell me what their thoughts are, but people accept things when they see value in it. And so if you're just going to, spend time with me and basically waste my time, and I see no value in adding to that, that might mean that I don't really want to waste my time. I know it sounds negative, but that's the fact. So if people see a value in something, I mean, over time we would be able to predict that you would be able to, get this disease or something. I'm just thinking out what could people see as the value, and I would be interested in what do the people from Nomzamo. Have you asked that? Have you tried to determine what do they see as the value of being part of this? Even more so when it's an informal settlement where people might feel that they might be unsure of their position in the society, being an informal settlement.
So what we've been very aware that to be part of an HDSS is quite burdensome. Like it's a lot of annoying questions that get asked of you all the time. But the hope is that because the community health workers are there, they're providing services, they're weighing the baby, they're checking on the pregnant woman, that there is some sort of usefulness in that encounter, and that if we can keep the questionnaire as tight as possible, they see the benefit in it. And maybe just to say that the sort of the biobanking and the genomic sequencing things is very much way down the line. But we thought because we are from the Department of Health, basic things like HIV viral loads and HbA1cs and sort of those kinds of information that we could also collect off a dried blood spot, which would be service relevant, as well as informing the research component. So there's lots of options to discuss there. But yes, we are very aware that we whatever we do in this platform has to be useful and meaningful to the communities that they serve. For the general. So I think the community is. It's a newer community. They are struggling a little bit more. There's much higher levels of informality, and so there is an openness to when we say we're from the Department of Health, we've come here. People open the doors. I think in Bishop Lavis it's a little bit difficult because they've been let down by government services repeatedly, many times, and so that complicates the relationship. But I think. Yeah, they in Nomzamo, we haven't had any issues around lack of participation or reluctance from the community. They've been very open and welcoming there.
I don't want to hog the microphone. Just lastly, is there anything around the fact that people might be at work during daytime more in Bishop Lavis versus Nomzamo?
Yes, so that's definitely one of the challenges, because even for COPC services, those are only offered at the moment during office hours. What the idea is that anyone in the household can answer the questionnaire. So it doesn't, if you've got a grandmother who's at home, she could be able to answer the basic questionnaire around the household. But we are introducing the overtime now in Nomzamo on a Saturday morning to try and get those last few to make sure that we're not leaving anybody behind. And just to add, the department has also had various discussions about differentiating care to meet people where they are. And so things like after-hour clinics being available after hours and on weekends is an ongoing discussion in that space as well. And so we do need to, we can't just do our standard, we're going to work from 8 to 4 and expect things to pan out. We do need to think a little bit more out the box, and particularly in a setting like Bishop Lavis, where there's other challenges at play as well. Yeah.
Any question from the online? Anyone who has any question? Yes, Dr. Juliet.
Yeah, thank you so much for such a great presentation on the project or program progress. It is indeed concerning that there is so much struggle in Bishop Lavis to the point of temporarily withdrawing. I think it is it can be a huge loss if the withdrawal is permanently. My question is maybe why do you think it is like this? Because I know that as Stellenbosch University, whenever we have social impact projects in Bishop Lavis, there's, very positive and good, response and participation by the community. Could it be that there were some challenges maybe upon entry? Maybe can we do some sort of like a qualitative sort of research or assessment to look at what went wrong, then what would be the possible solution so that we restart and involve the Bishop Lavis community? Thanks, over.
Yeah, I think that's a good idea. But maybe just to say that the problem with Bishop Lavis, there is no Bishop Lavis community. It's lots of different groups of people, and so it's when you have events, you will have a proportion of people will turn out. But to do a health and demographic surveillance system, you need everybody, and getting that kind of universal access and acceptance is difficult. And the sort of consolation, I don't know what it is. I know when our colleagues did the census in Bishop Lavis recently, they struggled a lot. And so this kind of household assessment in this community is difficult. I don't know if the colleagues from Bishop Lavis want to add anything there.
Maybe later.
Yeah.
Okay, as you think, Prof. English, you can go ahead.
Yes, thank you. I hope that you can hear me well. And apologies that I'm not there in person. I'm still recovering from an illness. So thanks very much, Hannah, for the presentation. I think just to respond to the questions around access to the communities, as Hannah had said, the communities are quite different. Nomzamo is new, but there's also cultural differences in the way that one can enter a community. So in Nomzamo, it's very much reliant on the fixed community leaders, as Hannah said earlier. In Bishop Lavis, it's heterogeneous, it's different communities, and there are long-standing issues in that community. So Hannah, I don't think Hannah mentioned that there is a community advisory board that was formed, and in the last few months, I think they work quite closely with Stacey Blouse to be able to expand the discussions with other members, particularly some of the members that have been working on other projects in Bishop Lavis. Because this project is linked to the Department of Health, there's also been close collaborations with the Northern Tygerberg substructure, which is a different substructure that they work with compared to Nomzamo. So there's also been challenges there in terms of being able to work more closely with government structures in being able to access. But the crime, the lack of trust, the difference in the community, many factors has made it very difficult. Hannah, if I may, and maybe you can expand on that, we'll tell stories about how the community health workers had gone in to do their work, but had to suspend work because of gun violence and being caught in the crossfire. Fortunately, no one injured. So that's kind of the daily realities of those communities. And that was what was seen through COVID, many other conditions that were faced. And so a lot, and then the last thing to mention is that there is the NPO that they work with, who employ the community health workers. And so there's another layer of actor involved or stakeholder involved in terms of being able to engage with the communities. And so there is a lot of work that needs to be done. And I think that my understanding is that this is that steps have already been taken to engage with the communities, but clearly there are a number of players that have to meet to be able to address this. I think the Bishop Lavis community members who are in the room, and because I'm not there, I don't know who's in the room, but there is a group online as well who have joined. Many of them are involved in other activities, community safety activities, the VPU, ABTs. So there are lots of structures, but this is a historical, deep-rooted problem. But it remains important for Stellenbosch University to support this project so that this particular population, which represents a minority population in terms of SAPRIN, we can get their data and also contribute to the work and learn from the work, given the long-standing relationship, particularly of the faculty with Bishop Lavis. Thank you.
Thank you very much, English. Prof. Berger, can you ask your question? Welcome.
Hello, good morning. Thank you for letting me join, and good morning from Munich, Germany. It is a very interesting talk, and I am very excited to hear about the data is collected. I was wondering, maybe it was too fast and I was not too attentive enough, but is there also data that would allow to evaluate NCDs, at least body mass index and blood pressure, or even blood data or information on diabetes or this type of illnesses?
So for COPC, we collect basic information about are you hypertensive, are you diabetic, what's your blood pressure, what's your blood sugar on a finger prick. We haven't systematically done weights and heights because it's actually quite complicated. With the community health workers need to carry scales which are heavy, and the scales need to be calibrated and things. When we do our individual level consent, we are going to be taking abdominal circumference because that's just an easier measurement for us. And then there are some questions asked around smoking as well. And then when we link the data with the existing health records at the PHDC, we'll then have their full medical history, so whatever they were prescribed, what the HbA1c is, etc. So, I mean, traditionally, the NCD data space at the community level has been a bit sparse, and we were trying to augment it now a little bit to at least get abdominal circumference and to be a bit more systematic with the blood pressure and blood sugar recordings.
So it's due to my background that I have no idea of what the community health workers can actually measure. Are they allowed to take measurements themselves? Are they allowed to take blood pressure, or can they only ask for it?
Yeah, no. So they can do those basic measurements themselves. It's just that the focus of community-based services has traditionally been around maternal and child health. And sort of HIV. So, they were very familiar with weighing the babies and measuring the babies and doing those things. But we haven't systematically really gone into the NCD space more, which is what we're trying to do now. And so we're going to introduce some very basic anthropometry at the individual level consent.
Thank you. Thank you.
Thank you very much for joining all the way from Munich. Yeah, we appreciate you joining. Ronel, can ask the question.
Good morning, and thank you for the presentation. It was good to hear, kind of just confirm what we already know about Bishop Lavis. My name is Ronel Bekes, and I'm a lecturer with the Division of Human Nutrition. So I'm a dietitian, and I started working in Bishop Lavis in the facility, doing student training in 1996 already. So I can confirm everything that you've said. So I think there are two things that I would like to just highlight is that I agree the community health workers are not really well equipped to do all these measurements. Professor Berger from Munich, we've done a research study with them last year in determining what their ability is to screen children for malnutrition. They don't have scales, they don't have stadiometers to measure height. So and the reality is also they must walk around with the equipment. So it's a lot of challenging circumstances for them. We expect a lot of them, and then it rains and the violence and everything. So it's difficult for them to do these jobs. And the other thing, so that's on the community health workers. The other thing is that I would like to engage with you also in discussions to the presenter, because I think we can I think I might have some ideas where we can meet with the people, maybe use a settings approach, use schools or churches or some other NGOs in the community where we can meet, because I've seen that the C# team or they have a gazebo there in front of the shopping center in Bishop Lavis, or the shopping mall, whatever that, in front of the shop, right? Which I think not obviously not everybody will go there to access or to see the advertisement for the initiative. So I think maybe if we can get together and share some ideas, and not only me, I think many of the other healthcare workers in the facility or in the community, also from Stellenbosch University, might also be able to contribute to these discussions. Thank you.
Yes, thank you. We welcome any support and advice and collaboration.
And thanks, Ronel. So yeah, feel free. I think that's why Hannah to come and talk to the community at Stellenbosch, so we can see how to maximize the C#, support it, but also utilize the data that is available. It's not supposed to be, sitting in computers. It's supposed to really generate evidence that we can utilize to improve the health and wellness of our communities. Yes, go ahead, Eunice. You are welcome.
Thank you so much, Anna and the team, for the presentation. Please, my name is Eunice from Burden of Disease Research Unit, MRC. I think the data, we'll be interested in the data. We have a study where we estimate the burden of disease for the country. So I think this data will be one of the we will benefit from it. So I just want to ask you, when will the data be available and we can access? I'm not sure if you mentioned that. Sorry if I missed it.
So the baseline data is available at the Provincial Health Data Center. I mean, maybe what would be easier if we can, I'll put my email in the chat and we can chat through if you any specific questions, and if the data that we have answers your question, and then take it from there.
Okay. Thank you.
Any other question? Prof. Susan, do you have a question?
Good morning. Thank you, Prof. Peter. I was just thinking, so I'm from physiotherapy. I was just thinking around the importance actually of us not leaving that community. I think the community, maybe the resistance is also related to the many stops and starts that have happened within the community. So I think it'll be really imperative for us to find ways of making this work, and also to the benefit of the community, because there's such a need and such a hunger for improving their lives. So I would also be like to be involved in just thinking it through at the community level of how we can optimize the structures that are already there. Thank you.
Thank you very much, Prof. Susan. Yes, yeah, I know you have special interest in the C-Sharp initiative, so please get in touch with Hannah. Yes.
Yes. Hi, I'm Nicola Plasto from Occupational Therapy. I'm sorry I'm late. I was listening online and then came in person. I think like Renal and Susan, I'm also involved in Bishop Lavis on a clinical level. And I think I just want to reiterate that we need to look at how we can work with the community to make the site work. And I think we have enough, if we put our heads together, there's enough resources across our community members and staff at Stellenbosch who have got long-standing relationships to try and look at how we can make the C-Sharp work better there.
Thank you. Yeah, Prof. Yankee, if you have any question, please.
Oh, sorry, Peter.
If you have any comment or question.
No, I'm just listening with great interest. Thank you.
Okay, wonderful. Thank you. Thank you. Trudy, any question or comment? Okay, anyone?
Nothing from me, thank you.
Go ahead. Yeah, go ahead, Trudy. Yeah, okay.
No, nothing from me. It was quite important to know what the community workers are doing currently and the scope for what can happen going forward. Thanks.
Wonderful, thank you. Anyone? There's a question. Okay. Yeah. Prof. Lo, you can ask the question.
Okay, I've posted a question just regarding the funding. So I hear the potential the colleagues who can potentially assist with coordination. But Hannah also mentioned that there is some concern regarding the funding as well to continue data collection in Bishop Lavis. And I want to know if the SU colleagues have any ideas of potential avenues that can be explored. Thank you, Peter.
Thank you very much. Okay.
I would be very interested in the answer to that question from the SU colleagues.
Yeah, but just a quick one. So you raised very important points that we need more people to be involved. Currently, we have only been 2 in the steering committee. How can we do that?
So I think that the steering committee is the sort of overall governance mechanism, and we only meet 2 or 3 times a year. And obviously, we need someone on the steering committee moving forward. But much more regular engagement would be helpful. We are doing that a little bit in the community engagement space with Renee and Stacey, but also potentially in the operational space, because just to reiterate, the sort of community reluctance or the sort of that is one issue in Bishop Lavis, but that's one of many. And the other major issue is around the NPO space and the capacitating the NPOs, the community health workers, the management, so the nurses who manage the community, all of that staff needs to be supported. And then, then there's the collaborations with the substructure, and there's external research projects. But if we don't get the community part right and the NPO community health worker part right, it doesn't matter what we do. And so both of those areas need additional support. Yeah.
happen. And everybody's working silos because everybody wants to be the CEO. Yeah, because currently, the reason why we had the hub, in the beginning, everybody was there. And then most of the community, there's a few that left because they couldn't understand the long-term plan of what we envisioned for Bishop Lavis. And then they came C#, which they should be on board. And it was only from the community organizations that was there where they, when the launch of C#, and that was the last. So how are we going to engage them on a regular basis to be still involved and to see the benefit of what C# is doing?
So that, I mean, that takes consistent and persistent effort and time. So you need people who's, this is their job. This is what they do full time, is they coordinate these activities and they send out the WhatsApp reminders, they organize the meetings. It can't be this sort of ad hoc thing done last minute extra. It needs to be very intentional, very planned, and properly resourced. We can't do this kind of intense community engagement with a shoestring budget. It's just not realistic.
So the just for my colleagues online and here, so the key thing is colleagues want to be involved. Okay, Prof. English, you can go ahead.
Okay, thanks, Peter. So if I may make a proposal, there is an ongoing, which is, I think it was Bernie that spoke, I'm not sure whose voice that was in the room. There is an ongoing engagement as part of other work that our division does, and that's the hub that was referred to. And that is also the members that that Hannah engages with quite a bit, outside of the CAB. So I'm wondering if that forum, which is really a space held by Stacey Blaus at the moment, who is also doing her PhD on university community partnerships in Bishop Lavis, whether through that process, as well as Prof. Lowe's got some engagements there, I know, through her staff and through other work that we are doing collaboratively, whether we could expand that hub that meets just about every second Wednesday, have a portion of that hub dedicated to C# activities, and then that is an open invitation for everyone to join and to think through how to take things forward. We could maybe have an offline discussion with the key people, Prof. Nyasulu, under sort of your guidance, as to who the best people would be to lead that smaller engagement, and that could then become the link between C# activities, between SU's activities, and as time goes by, something more formalized can come out of that structure. So that's what I would propose going forward. Thank you.
Thank you, Prof. English. I think the goodness is we have people, so we could throw it over to make sure that those who have the interest should actually contact you and then join the meeting. I think that would be possibly the easier way forward. I'm sure there are quite several colleagues here who are excited about getting directly engaged with C#. Let's allow Graham, go ahead.
Good morning, and thank you for the opportunity. Sincere apology, I logged in very late, was struggling since 10 o'clock to log in, so I might have missed quite a lot. I work within the Bishop Lavis area, very close with Prof. English and Stacey and them as well. And I have a good idea of the C# project from community side, because we don't understand the need, how the need arose for C# to move out of the area or to stop with whatever they were doing there. For us, digitization is important, and we want it there. We just feel, and I think Prof. English touched on it as well now. We just feel that the engagement that there should have been with community leaders and community members and organization wasn't there in the first place when it was brought into the community, which should have taken place, and even now with the decision to go out of the area or not to fund certain aspects of that was not done with the community. And I support the idea of a meeting, but a very, very urgent meeting with key stakeholders within the area, so that we can thresh out what the issue is, because we have an idea of where the problem could be, and we just keen to sort it out. We just keen to make sure that project becomes a success, because that project for the future of our community and the children within our community is very important. Thank you very much.
Thanks very much, Graham. Those are very good highlights. We appreciate you. Thank you. Any more questions? Any burning issues? So we have actually been given the key highlights of the C# project as Stellenbosch University and our partners and collaborators. And thanks for joining from Munich, because you have special interest in this project. And I remember when you came, you visited the site briefly. So we appreciate that we can work around improving C#'s data collection on NCDs, which are some of the key areas of interest. But also, Prof. Nico, thanks for joining as champion of research at the faculty. I hope you will be able to catalyze some initiatives on how we as an institution can get more engaged in the C# activities. Our site really is Bishop Lavis, where we are supposed to actually be more involved. And we, I think we'll talk behind the scenes and see how we can, support the initiative even better with the support of our executive at the faculty. And our colleagues from Bishop Lavis, and thanks very much for being part of our journey. We appreciate and thanks for coming, braving the cold this morning all the way. And my colleagues from the faculty here and those who are online, and thanks very much for being able to join this seminar series as part of Global Health. But today we focused on the C# initiative, which is really a research infrastructure where we can have direct access to the data and answer any other question that we may want to answer in population and health sciences. So, and to Dr. Hannah, thanks very much for your time and for leading the C# from its conception up to now. All the steps that has taken, the challenges, the successes. You have been part of the story, and so we appreciate that you are able to come and share the progress of C# so far, and also the challenges that are being faced. And so we'll see what else we can be able to support with. And so, do you have any last words?
Maybe just to say that we welcome any support and collaboration and working together around Bishop Lavis site. We don't want to lose it. That's why I'm here, is to say that we don't want to lose it at all. But also don't forget about poor Nomzamo. They're also part of C#. We have data. They're in the Tygerberg drainage area. So yeah, thank you.
Yeah, so thanks very much. There's tea and coffee outside, so please have have a cup of coffee and some